Well, good evening, everyone. Welcome back to our Exam Pro webinars for this Tuesday, October 6th, 2020. I'm your host for this evening, Bob Pegues. Before we start, I believe all of you have received the email from the American Board today notifying us that the American Board has made the decision for this year to suspend oral examinations in January and February of this year in person. In lieu of this, they will be offering instead, as you know, a written examination, which will be offered to all candidates at once online on February 2nd. This obviously changes everything for this year as far as how we would be thinking about the examination. However, speaking as someone who has been a medical educator for 30 years and who has worked in board preparation for about 20 years, I think I can say that the way we are preparing for the exam and the materials that you have should be more than adequate to get through this. This written exam obviously will be different from the written board qualifying exam that we all took at the end of residency, because the examiners have to test us on oral board concepts, which involve our application of concepts to our practice, implementation of sort of protocols as far as going through differential diagnosis, triaging, developing management plans, weighing the strength and weakness of evidence, developing an ongoing management plan. And over the past decades, surgical specialty testers have become extremely sophisticated, as we know, in being able to test us, not only on what we know, but how we think. And in fact, at Exam Pro, for over a decade, we have been offering a specific course of the written examination on how to approach the written exam from this point of view. So ABOG is very good at this, and they are going to be structuring written board exam questions for the oral exam that test us on the same sort of things that we would be talking about in an oral exam format. So the Exam Pro directorates have asked me this evening to move instead of our case list review to a structured cases session. And since I sort of oversee the written board examination preparation, especially the strategy for the board exam, what I thought we would do is walk through. I put together a new set of structured cases here. I'd like to walk through them and practice them as we do. And I'd like to go as we walk through here and discuss how I think the board examiners will use the sort of information that we are working through and the knowledge and discussions we have, and we'll develop some written board examination questions. And we'll probably talk about a few possible questions for each of these topics. And going forward, I think it is still useful. We should use our case list, because the sort of things that we discuss in defending our case list are going to be the sort of things we need to think of in our heads when we're answering these sorts of board exam questions, which is really an oral board exam transferred into a written format. The structured cases are going to be very much the same. The knowledge topics that we'll need to know, the information we'll have to have at hand, and the way we sort through what's important and not, where it's not important, where do we start to solve a problem, what are we thinking of as we go along the way, can very easily be put into written board exam format questions. And we'll spend some this evening practicing that. So this is, again, not a time to think about moving over to reading textbooks. That is not the way to study for a written board examination. I think we should use the tools that we have, which are your case list and your practice bulletins and the information, the manuals that you have that you're studying for the exam, and start to think about sort of thinking in the way that we would talk and starting to imagine how that would work in a written board exam format. So let's get started on that right away as we're moving through here. For those of you who would like to participate, I have 9 structured cases here. We'll get through as many of them as we can. And next week we'll take up any more, and we'll put some more together as well. Please do click the raise your hand button if you would like to participate, and we'll carry on as we usually do. And as we go through, we'll sort of talk about how to start thinking about things in this new format. So for any of our candidates who would like to participate, please do raise your hand, and we'll get started here in just a moment. Thank you, Samantha. Let's get together with you right away. Samantha is always good at volunteering. Samantha, I'm just trying, there we go. I had you unmuted and then I messed that up. Let's try that again. There you go. Samantha, can you hear us okay?
Yeah, I can hear you.
Great, thanks for joining us. And Lindsay, thank you. I'll be with you in just a minute. I think we'll plan on working on, let's finish so that we have a few minutes at the end, and I would like to open it up for questions, because many of you may have some questions about what now is going to happen on February 2nd. This is all new, but we will do our best. I will do our best to answer the questions, and we're all meeting Exam Pro. The directorate is meeting in the next few days. We'll have a plan out to help. ABOG, as you know, is hosting a webinar on October 13th that we should all be tuning into, and they will give us more information about what they are planning here. They will certainly not show their hand as far as what the questions are going to be like, but it will give us a little bit more information on how to manage the next few months. But fortunately, we really do have at this point a solid 4 months before we have to face this exam, plenty of time to prepare. So Samantha, let's start in. I've got a case up here for us. A 35-year-old woman presenting for prenatal care reports that she is HIV positive. So case initial OB visit here. Part A, discuss your medical management of HIV in pregnancy. Let's just start there. It's a broad topic and you can start in anywhere you'd like to, but the idea is you now discovered she's HIV positive, so we have to pick a starting point.
So I think my management would depend on when her HIV diagnosis was made and if she's on any current therapy. If this had already been previously established and she's on therapy, I would coordinate her therapy both with her HIV or infectious disease provider, as well as with my maternal fetal medicine colleagues. If this was a new diagnosis, I would still involve the same above noted consultants. And for either scenario, what I would want to know is what her viral load is and start her on a medication regimen to keep that viral load low. So that we could potentially have a vaginal delivery by the end of the pregnancy. I would also continue all routine prenatal care, and I would ensure that she's up to date with her cervical cancer screening, as well as being tested for all other sexually transmitted diseases.
Great. Sounds actually very good. Let's move on from there for a moment to part B. Discuss your management considerations at delivery. Then we'll come back and get a little bit more on part A, but go ahead with part B.
I think my considerations, my management considerations for delivery, again, I would discuss this with maternal fetal medicine. I do not believe that HIV is an indication to have a delivery before 39 weeks, but it could be considered at 39 weeks depending on what her disease course is, with the goal to have a low viral load. I don't remember the exact cutoff. I want to say it's 20,000, but I would have to double check that.
I'm sorry, this is a cutoff for considering what?
A viral. So if the viral load was lower than that, I would consider a vaginal delivery, and if it's higher than, I would consider a cesarean section.
Got it. The viral load is 1,000 copies per mil.
Okay.
So above above 1,000, yeah, above 1,000 cesarean, below 1,000, considering a vaginal delivery if we don't have rupture of amniotic membranes, anything else going on. And for the delivery for HIV, it's actually specifically recommended that we deliver at 38 weeks, not 39. That's sort of an outlier, but it's just in anybody who's HIV positive. That's just something that's just, it's kind of like for di-di twins, the same thing, 38 weeks. But we're at 1,000 for the viral load. But carry on there. It sounds like you're getting into a couple important things for us to think about here.
I think that's it.
Okay, so it's about vaginal versus cesarean. And it says if viral titers are undetectable, when would you deliver? That's the question that we just actually answered a moment ago, I think.
And I guess I would also include in that, it also depends on if she has any other comorbidities and any other reasons to have delivery at a different time. But if everything was otherwise normal, then consider delivery at 38 weeks, as you said.
Right. So the answer for C is if viral titers are undetectable, we're going to deliver by 38 weeks no matter what. If our viral titers are very high, we'd still deliver by 38 weeks. It would just be by C-section. The management considerations of delivery are when we're going to deliver her, is what's the route of delivery going to be? And the other thing that we talk about is there an indication for giving interpartum HIV prophylaxis, or like zidovudine prophylaxis or something like that. Part D says if the viral load is high, when would you deliver her?
So it would be the same answer.
It would be the same answer, exactly, yes.
Except that the route would be a cesarean delivery rather than a vaginal delivery, and the purpose is to prevent transmission to the neonate. And I know you didn't ask this question, but I want to answer it anyways.
Yes, please do.
Purposes. But I also believe that the neonate would get I think an early bath and also some prophylaxis, but I don't remember what it is exactly.
the pediatrician, they might actually give zidovudine or something like that. That's true. Regarding Part B, for the management consideration to delivery, generally the standard has been if the viral titers are above 1,000, you would usually give a zidovudine at delivery. There's been some recent discussions that you can offer your patients zidovudine even if their titers are under 1,000, and they're talking about sort of titers in the range of maybe like 50 to 150 or above. You might do that as well, and that's sort of an evolving consideration there. But if I were answering this in an oral exam format, I would mention there is a consideration to doing prophylaxis with zidovudine if we have a higher titer. That may actually help further in somewhat reducing risk of vertical transmission to the baby. Now, Samantha, thank you for going through this. Now, as far as how our discussion that Samantha and I just had would play out in an oral examination, for instance, we could take Part A. A 35-year-old woman presents for prenatal care. You discover that she is HIV positive. The next most appropriate step in this patient's evaluation is, that's a really common format for questions, as we know from having taken our written board examination. A would be rapid HIV titer. A. B would be HIV ELISA testing. C would be Western blot testing. D would be CD4 counts. Next most appropriate step would actually be to do the ELISA testing. We would do a rapid HIV only if she had turned up, in labor, unregistered, had to know right away if she's HIV positive or not. This is a new OB visit. The Western blot is a confirmatory test. You would do that if the ELISA turned up positive, and you do CD4 counts only when you're working her up. So that's an examination. That's an example of how a question could be structured that makes us sort of think through how we're managing this patient as well as our knowledge. For management consideration to delivery, it could be delivery of a patient at 38 weeks by vaginal delivery would be contingent upon the following. And you could mention a HIV titer of 1,000 or below, HIV titer of 500 or below, absent rupture of amniotic membranes, or all of the above. The answer would probably be all of the above. I think you get an idea of where we're going with this. You could develop a similar question for the zidovudine prophylaxis and when that should or should not be administered. There are 4 or 5 questions I think that we could just write out that would come out of this, but the way those questions are worded, it makes us use some knowledge, and it also makes us think through sort of evaluating the strength and weakness of information. What is appropriate as far as a consideration? What do we rule out as a consideration? Or in this question, are all of the above a consideration? And those are common question topics to walk through in a question like this. Samantha, thank you for going through that with us. That was actually a very nice discussion. And HIV is certainly a common topic in the exam. Let's go up to Lindsay for just a second. Lindsay, you're self-muted. Can you unmute yourself for just a second? Let's see. Oops, we had you there. Almost had you, sorry. Lindsay, if you can unmute yourself for a second, we'll get you on and we'll do a question here. See if I can get you. There we go, got you. Lindsay, can you hear us okay? Lindsay, are you there?
I am.
Oh, good. Thank you for joining us. Can you hear us okay?
Fine. Can you hear me now?
I can. Yes, I think we're good. Yeah. Can you do question number 2 for us? Let's see. It's going to be a GYN question because we're just rotating, but let's see what this is. 28-year-old woman consults you regarding initiation of HIV pre-exposure prophylaxis, or PreP. Part A, how will you evaluate her as a candidate for PreP? This is a more recent topic and something that actually we heard turned up in like the January and February exams last year, and I'm pretty sure it's going to be on the exam this year. So this is something good just to talk about. So this is about pre-exposure prophylaxis for people who are trying to reduce their risk of exposure to HIV if they're in a certain relationship where they might be exposed. So the questions are, how do we determine whether she's an appropriate candidate for HIV PreP?
By taking a history and I do not know this.
No, that's okay. That's okay.
Risk factors in the history would guide me to if she were a candidate for pre-exposure prophylaxis.
Good. What sort of risk factors might you think of?
So a sex worker or multiple partners, but I don't know what number that would be.
That's okay.
Or if they were in a relationship with a known HIV infected person.
Great.
And immunocompromised could come into play there.
Okay, good. You just answered part A of the question. The people who we'd consider for this HIV PreP, and there's an excellent FDA summary on this. If you want to go on the FDA website, it's really good. Is multiple sexual partners, either heterosexual or it's actually men having sex with men, but it's not women having sex with men. So heterosexual multiple partners, and that would be sex workers also, or MSM, and what they call HIV discordant heterosexual partners. So one partner has HIV, the other does not in a heterosexual relationship. And you basically cover those, exactly. So and those people would be candidates. How will you counsel her about the effects and limitations of HIV pre-exposure prophylaxis?
So, I imagine that it's not 100% effective.
That is true. That's really important. Just like birth control pills, they are not 100% effective. Very good.
Counsel her to continue to use condoms and emphasize that this is only a prevention for HIV and not for any other sexually transmitted diseases.
Excellent. That's terrific. You're doing great. That's exactly right. If you go through the FDA monograph, they have listed, actually, it's part of a comprehensive prevention strategy. And what you want to counsel the patient about is you have to use it consistently. It's consistent daily use. You don't just use it, at the time of sexual activity or exposure. You do have to use sex precautions all the time. You do have to counsel the patients that it only is effective in reducing HIV exposure risk, not any other STD at all. And for that reason, it's in there that they should have very regular STD screening, and they should have regular HIV testing to be sure that they don't convert. And one of the key things about this pre-exposure prophylaxis is if somebody converts and becomes HIV positive on it, it's only a 2-drug rather than a 3-drug protocol. And so they are high risk of developing HIV resistance to the medications, which is dangerous for them. So if they're on it, it's consistent use. It's discussing the limitations of use, and it's a reduction strategy. It is only for HIV. They do need to use safe sex precautions, and they have to regularly, it's like every 3 months, undergo STD testing and including HIV testing. And if they seroconvert, they have to stop immediately and go on the full treatment, as you would imagine. That's actually it. You got that. What care will she require from you if using HIV pre-exposure prophylaxis? We kind of answered part of this question already.
You said regular screening for other STDs.
Regular screening for other STDs, that's right, and for HIV as well.
Absolutely. As well. And then, I mean, I imagine you would just want to touch base with her and make sure that she's following, taking it every day and continuing to be compliant, and assessing her risk factors for STDs.
Yeah, the concern for HIV pre-exposure prophylaxis, this is what is going to make it a really good board exam question, is it's risky. If people do not use this the way they are supposed to, they are at actually increased risk of contracting HIV. And if they do so and they don't know it, they are at increased risk of rapid development of resistance of HIV to their medications. And then their prognosis is actually much poorer. So this is something that requires a fair amount of effort on the patient's part and a fair amount of effort on our part, because we have to review with them regularly that they are using the medication consistently, they're not missing doses, they're using safe sex, they're having regular HIV testing, they're having regular STD screening. It takes a fair amount of work. There are a couple other things. The important other thing to know for all of us for the exam is that hepatitis B is a really key factor here. These people have to be screened HIV negative and hepatitis B negative. Because if they actually go on this medication and they're hepatitis B positive, it can cause their hepatitis B to flare. And that's actually dangerous for them as well. So the risks of pre-exposure prophylaxis are, again, if they become HIV positive during use, they develop rapid resistance to the treatment. If they're hepatitis B positive, they can actually get an acute flare and they can get hepatic injury from it. There are a couple other things in there, people that we should counsel about. People who are on HIV PreP are at higher risk of developing serious hepatomegaly, actually, even if they don't have liver effects on it. And lactic acidosis, I have no idea why that is. look for references on that if not. But if they had a board exam question and they were talking about what are risks of pre-exposure prophylaxis, it would be HIV conversion, which puts them at risk of resistance. Becoming hepatitis B positive, being hepatitis B positive, they cause a flare of hepatitis and liver injury, lactic acidosis, and severe hepatomegaly. And in the literature, it seems to be hepatomegaly great enough that they're at risk of stuff like hemorrhaging from rupture of the hepatic capsule and stuff like that. So this is a fairly high risk adventure to undertake with our patients if we're doing HIV pre-exposure prophylaxis. And for that reason, I think it's something that would turn up on the exam. So written board exam questions for something like this would be very much along these lines. We'd need to know the importance of hepatitis B in there as far as being a limiting factor on whether we can prescribe it. We have to know that they're HIV negative. Also, they have to screen out as having any other of the other particular risk factors for liver disease and such, and they have to have regular testing. And we can construct a number of questions for part A. It could be appropriate indications for offering HIV pre-exposure prophylaxis include, and it would be just sort of one of the four. It might be women having sex with women, sex workers with multiple sex partners, recent conversion of HIV status to positive, or all of the above. Of those four, obviously the only one is women who have multiple sex partners. Everybody else is not a candidate. So those are the sort of ways, again, in which we should start thinking as we're preparing for this new exam, as far as when we practice these things and talk to them about ourselves. In your mind, start kind of making up just 4-part multiple choice questions. We could construct 4 or 5 for this topic also. Lindsay, thank you. That was a topic that, again, is fairly new. We were not expecting anybody to be really good at it. But one thing that Lindsay did show us is in the exam, in oral exams, you get a question like this that's cold and you don't know it, but she talked her way through it actually really pretty well. She would have been given a pass for this question, actually. When we are looking at a written examination, the same thing happens. A question like this pops up, and we may not be familiar with this topic at all, but if you go through and you just take all 4 answer choices and just eliminate the one that you think is the least reasonable, and then look at the 3 that are left, and get rid of 1 more of those, which is generally moderately reasonable to do, you're down to 2 answer choices and you have a 50-50 chance of getting it right. And you can do that generally within 30 seconds. And in a time pressure or examination, that's the same sort of thing as talking your way through a question and just sort of letting things come to your mind as you're working it out. It's just backward. It's eliminating things one by one that seem to be least reasonable and getting down to the closest answer. Lindsay, thank you for doing that with us. Is there anything that you would like to talk about, or just any questions you have before we move ahead? Lindsay, are you there? I think we lost Lindsay. That's okay. Let's go on to Melissa, who's been standing by. Oh, Lindsay, you're there. Sorry.
Oh,
go ahead.
Sorry, I just said no, thank you.
Okay. Thanks. Thank you for doing that with us. Thanks. Let's get to Melissa. Melissa, can you hear us okay?
Yes, I can.
Okay, we're going to do an office practice question next. So we talked about this once before in the season. What are the high and low cutoffs for maternal serum AFP?
The high cutoff is 2.5 times the multiples of the mean, and the low cutoff is 0.5.
Perfect. 0.5 to 2.5 multiples of the median, which is slightly different than the mean. But that's fine. It's just MOM. So at 16 weeks EGA, a woman's maternal serum AFP is returned at 3.3 MOM. The reason, again, they ask you at part A first is you have to sort of know that 3.3 is a high MOM, and this is a high abnormal test. So next part of the question then will be, what is your differential diagnosis in this case?
Differential diagnosis would be, it could be an inaccurate estimated due date. It could be a neural tube defect. It could be gastroschisis.
Yeah, good. So Melissa is thinking about neural tube defects and abdominal wall defects, and that's important. You're right. And I like you, gestational dating error. Yes, suppose that this woman is actually 14 and a half weeks rather than 16 weeks. That would bump her up into looking like she had a high AFP. That's right. So dating discrepancy, neural tube defects, abdominal wall defects. Anything else we should think of, or are we good there? If you want to be good there, that's okay.
I think I'm good there. I have some other ideas, but I'm probably just like throwing them out to the wind.
Those are the important ones. AFP is made in the fetus. It's in the central nervous system. It is in the liver. It actually is in the marrow as well. The placenta is also a source of AFP. So at some point we're going to get to, when you have a false positive AFP, placental sources become more common. So for this question right here, I might make an exam question. It would be something like a woman's MS possible causes of a elevated maternal serum AFP test at 16 weeks include number 1, dating discrepancy, number 2, neural tube defect, number 3, gastroschisis, number 4, omphalocele. Which of those does not belong? So it would be each of the above except omphalocele would be the one that does not belong because it's not an open abdominal wall defect. So that is a way in which they could take the information that we use and they can construct a little bit of a tricky question that causes us to think a little bit, but it's working through the same differential diagnosis. Part C, so how would we evaluate this finding? So AFP is 3.3 MOM. You've given us a good differential diagnosis. How would you work this up?
I would offer, you could offer diagnostic testing with the amniocentesis. You could also, I would also order an ultrasound to see if at this point we could determine if there was any gross anatomic abnormalities.
Yes.
And that's it.
Okay, so we're going to offer an amnio. We're going to offer an ultrasound. You're looking for those anatomic abnormalities. Anything else that you might do? You did, in your differential diagnosis, you did mention one more thing that you might want to check out here.
We could do a growth, trying to determine how you would determine inaccurate dating.
Oh, no, I think, wait, I would tell the examiner, I go back and review her gestational dating. Did I have the correct EGA? I look at her menstrual period, her first trimester ultrasound. Does that line up, or did we put a wrong number on the report?
Gotcha.
Or, does it, or could she possibly be like, does she actually have no menstrual period and her ultrasound was 1 week ago? And so it has, maybe a 10-day error on it or something like that. So we could do that. Sure, but I agree. I would evaluate the dating to be sure it's correct. Anatomy ultrasound, looking at the neural tube, abdominal wall, liver, major organs, stuff like that. Offer her, you're right, specific diagnostic testing for the amniotic fluid AFP, which is what Melissa was referring to when she said an amniocentesis. Good. So for this part of the question, and how they would put that in the written board exam question would be, let's see, in evaluating an elevated maternal serum AFP, appropriate steps include each of the following except number 1, repeat serum AFP, number 2, review of gestational dating, number 3, anatomy ultrasound, number 4, amniocentesis. The one that's not correct is a repeat AFP. Once you have an abnormal level, you have to go on and evaluate it. And that's how they would put that into a written board exam question. And Melissa's already given us all the information that we need just to think our way through and answer that question. Now, part D, amniotic fluid AFP is normal. What are your concerns and how would you manage this situation? So now we're talking about a different category of differential diagnosis, I think, right?
Right. So then at that point, you would be concerned that this is a placental issue.
Okay. Yeah. So it's a false positive AFP, and that generally does put it in the category of placental issues. I agree. Yes.
And how would you manage? I guess you could observe, look at the ultrasound or look at the placenta on ultrasound to see if you see any abnormalities.
Okay. Well, I think it says, what are your concerns? Are there things that we're concerned about as far as risk to the pregnancy if we have a false positive AFP? Gotcha. In other words, if it's coming from maybe the placenta, does that pose risk to the pregnancy?
Yes, because you could have placental insufficiency.
It could. That's right. Yes. And what sort of things would that lead to that we might want to be checking out as we go through the rest of the pregnancy? That's important.
It could lead to intrauterine growth restriction of the fetus, which is the main thing. It could also lead to, I'm sorry.
Yeah, go ahead. And what else would you say?
It could also lead to like preeclampsia.
It could. That's true. Along with the IUGR, if we had placental insufficiency, is there anything worse than IUGR that could happen?
IUFD and fetal demise.
Exactly. So a false positive, a false elevation of AFP or a non-neural tube elevation is term FDIU, IUGR, preeclampsia is also in there as well. So we got 3 things we're concerned about. Anything else that we should be thinking of here? There are a couple more. But you hit 3 big ones.
Preterm delivery.
Yes, preterm delivery is another one. And then there is one, and I think we talked about this case back in August or so. There is something that actually the pediatricians need to know about because it affects the neonate and baby. It's after delivery, and it's dangerous. It's potentially fatal to the baby.
Like a respiratory distress? I'm not sure. I can't remember.
Like that. It's actually sudden infant death syndrome, SIDS.
Okay.
And this is a New England Journal article from like 7 or 8 years ago, which got everybody's attention, that substantial increase in the risk of SIDS up to 6 months or more after delivery if you have one of these. So it's important for all of us to know if we have a AFP, that's elevated and we work it up, we can't find a cause for it, and it's sort of we call it unexplained AFP elevation. So FDIU at term, IUGR, preeclampsia, preterm delivery, and SIDS out to 6 months, and we need to cover all of those bases. And then all of those are actually important because all of those have potential serious risk to both the mom and the baby. So that's the answer to Part D, and you could construct any number of exam questions which sort of tested you on that you know all 4 of those, and that maybe all of the above are correct. But those are all important things to keep in mind. IUGR and FDIU, preeclampsia, preterm delivery, SIDS out to 6 months or more. So always let your pediatrician know. Good. Well, listen, that was actually a really nice run through, nice discussion of a question that is probably a perennial return question on the exam. Is there anything you'd like to chat about, or just any questions you have before we move along here?
I did have a quick question back on the first case.
Yeah, sure. That was HIV positive, right?
Yeah, it was the HIV positive patient. So even if she reports, so I feel like somebody wouldn't necessarily lie about HIV positive. So why wouldn't we just move straight to the Western blot to confirm it? Why would we do like a 2-step? Is there like a cost benefit?
Everybody's supposed to get an ELISA, and then the laboratory uses the ELISA to confirm a Western blot. We don't usually order a Western blot. So the 2 things that as practitioners we order is the ELISA for everybody. That's our screening test, and if somebody turns up with a report of being HIV positive, that's how we confirm it. And then the lab, if that's positive, does the Western blot. The other test that we would use is the rapid HIV RNA titer.
Right. So
if we need to know quickly.
Can you not do a Western blot without the ELISA then?
The ELISA, the Western blot is a confirmatory test for the ELISA. So we're supposed to do the ELISA first, and then the lab will reflect to the Western blot if the ELISA is positive, but it's not something that we order directly.
Okay.
Yeah. So our tools include ELISA test, which is standard screen, and rapid HIV titer if we have to know really, really fast.
Okay.
With some limitations. Great, thank you. Thank you for taking that on with us. Let's go, I think, to Ruth, and then we'll get to Evan for a minute. Dr. Romala, just a minute. Ruth, I'm trying to get you unmuted here. Oh, I had you there, sorry. Hang on just a second. There you go. Ruth, can you hear us okay?
I can.
Good, thanks. Let's do, this is gonna be back to an OB question for our next one, I believe.
Well, thank you.
There we go. A patient at 10 weeks gestation presents with intractable nausea and vomiting of 3 days duration. Part A, how will you evaluate this?
The first thing I would do is find out if the patient has had any contact with a sick or any sick contacts, if they had a difference in the type of food that they ate, or if they ate like specific things such as potato salad or fried rice that was bad. So I'm trying to find out if they've had any environmental factors. I would also find out, if there's a different timing of the day, if it's more in the morning or at night. And then I would also find out if she is having all other symptoms such as fever, chills, diarrhea. And then I would do run her vitals to make sure and confirm that that's not just subjective, looking at her fever, her blood pressure to make sure she's not dehydrated. Next, I would do a physical exam, looking at her mucous membranes, making sure that she's not completely dehydrated, listening to her heart and lungs. And then I would go ahead and do an ultrasound. I'm looking for singleton versus multiple gestation, looking to see that she does not have a molar pregnancy. After that, I would send her for laboratory work. The things that I would be looking for is to make sure her electrolytes are normal. And then I would be measuring her HCG quant to make sure it's not highly elevated. And then this I'm not quite sure about, because I think I read in one of the practice bulletins, I think it was the thyroid practice bulletin, that with a nausea, vomiting of pregnancy, you don't need to get a TSH. I used to, so I'm not quite sure if you can help guide me about that, but I normally would get a TSH.
Okay, well that might lead into, I don't think that is part B. Let me just check part B. Oh, it is. I wanted to ask you, so what is your differential diagnosis? So let's go into that. So let's do a brief differential diagnosis, and we might put thyroid somewhere on the list. So maybe let's the top 4 or 5 things that would come to your mind here.
So infectious causes, including viral gastroenteritis and all other infectious causes. I would think about pregnancy-related causes, including nausea, vomiting of pregnancy, hyperemesis gravidarum, multiple gestation. And then I would think about endocrinopathies, including hypo and hyperthyroidism, given the fact that TSH can behave as HCG. That would be my broad differential.
Okay, that sounds good. And let's stop there. There are 1 or 2 more things we could add in there, but I think we're pretty
molar pregnancy.
That's
I would
that was the one I was waiting for you to say, molar pregnancy. That was the one I was thinking. Yeah. GTN is it's always good to keep GTN in the back of our minds when we're doing the GYN questions on the exam, because they love that topic. So as far as how this would approach, just briefly, in a written board exam format, I'm just creating these off the top of my head because I write these questions all the time. I might say when they were looking at the differential diagnosis, a possible cause of intractable nausea and vomiting at 10 weeks gestation include each of the following except viral gastroenteritis is A, hyperemesis gravidarum is B, hypothyroidism is C, molar pregnancy is D. The one that does not belong would be hypothyroidism, because hyperthyroidism is associated with intractable nausea and vomiting, but not actually hypothyroidism. So that is, again, a way in which we'd have to use that information, and they make the question tricky because we have to read it very carefully. Another one would be a patient presents at 10 weeks with intractable nausea and vomiting of 3 days duration. The most likely diagnosis is, and it would be viral gastroenteritis, hyperemesis gravidarum, multiple gestation, or hyperthyroidism. It's a tough distinction then between viral gastroenteritis and hyperemesis gravidarum, but if she's 10 weeks pregnant and has been intractable for 3 days, I would go with hyperemesis gravidarum over gastroenteritis, which is usually a fairly self-limited thing. So this is how the examiners test us on our judgment and our ability to weigh the strength and weakness of evidence, and to work down a differential diagnosis and prioritize things. And this is how, in a multiple choice question, they do this. And our written board exam is all about this stuff. And I think they are going to take this approach and they're going to make it a little bit more so it emphasizes more our thought processes, and the knowledge is sort of moved a little bit off to the side. But this is where I think they will be going with this exam. So we're just practicing as we go along. So carrying on, Ruth, you're doing great here. Part C, ultrasound identifies a 14-week size uterus with no fetus identified. How will you manage this? And before we should get to how would you manage this, what are you thinking now as far as a differential diagnosis, or what moves to the top?
So moves to the top is GTN.
This is a molar pregnancy. This would be a complete height to 10-form mole if there's no fetus identified. 14 weeks, size greater than dates, right? By 4 weeks, no fetus identified, intractable nausea and vomiting. This sounds like it's a complete mole. Perfect. So we're now talking about GTN. So then how would you manage this?
So that's, I would, at this point, I would get an ultrasound if I haven't already. But you already kind of said that the ultrasound, so we got it. Yeah.
So we know we have a non-viable pregnancy, right? And we've decided it is most likely a mole.
Yeah. So I would.
We can manage it presumptively based on that, I think.
Yes. So I would do. I would discuss the findings with the patient, and then I would proceed to discuss surgical management.
Good.
With the patient, and I would take the patient to the ER for dilation and extraction, with the idea that I would need uterotonics in case the patient has a postpartum hemorrhage or a post-extraction hemorrhage, and I would be sending all parts to the pathologist, and then I would be monitoring the patient's beta HCG quant Q weekly until undetectable.
Good.
And then I would also discuss.
Oh, you can go. Yeah, go ahead. I'll give you just go ahead.
I would also discuss with the patient to make sure that they are on contraceptive post-op, given the fact that I don't want to confuse the trending of the HCG in case she was to get pregnant again. So we will talk about contraception long-term.
Good, perfect.
That is not an IUD.
That sounds perfect. So as far as acute management, it sounds like we want to recognize that this is sort of more of a high-risk procedure, but we need a uterine evacuation. So the question might be, they might just construct a written board exam question where they ask you to choose between medical and surgical management. This would clearly be a surgical management problem. You would choose that answer choice. You're right. What are the complications that we need to prepare for? That would be another great multiple choice question. So you mentioned postpartum hemorrhage. Would be uterine perforation is increased in these cases. You can go through a list of complications. You mentioned that you would be preparing with uterine tonics for postpartum hemorrhage. You send all the parts to pathology. Is there any other preparation that you would make in advance of the OR in a case like this?
I usually tend to have the patient try to get an ultrasound in because I want to dilate.
Yes, ultrasound guidance is great. Yes. As far as stuff that you might order or set up though before the OR, anything else? Particularly related, you said there's a risk of postpartum hemorrhage here.
I will have the blood type, so I know the RH test. Exactly. Yeah, and then I'll have the patient type and cross.
Type and cross, that's what we want to do. Perfect. And with that, I think you have nailed everything that the examiners would want to hear in this question. That was actually really nicely done. Thanks. Is there anything you'd like to ask about or just anything you'd like to add to what we've talked about?
No, the question I have is, how long do I, and this is like a real question because I don't know the answer. I'm not just asking it. How long do I trend the HCGs? Is it till it's less than 5?
It is, well, we want to get to a negative, and that depends on your lab. Well, less than 5 may be negative, and less than 3 may be negative. It needs to be what your lab considers as a negative. And usually we do them weekly, and we're supposed to get 3 weekly negatives. So when it gets a negative, hit it until you have 3 negatives in a row. Then you go to once a month, and we're supposed to have 3 monthly negatives in a row. And then we're supposed to go to every 3 months. And it used to be that we would do that for out to a whole year. The oncologists now seem to be comfortable stopping at 6 months. So depending on how long it takes you to get down, weekly and then monthly, you might just be doing maybe 1 3-month follow-up. But it's basically negative weekly times 3, monthly times 3, and every 3 months after that out till when you hit 6 months or whatever happens sooner. But that's always been the standard protocol for that. And you're right, the effective contraception or abstinence is important because any recurrent titer, you then have to work her up for GTN. Even if she might have an early viable pregnancy, she's got to go through the whole GTN workup.
Okay, and then the other question I have is, in my practice setting, I don't have a GYN oncologist like practicing with me. Sure. So, or I would have to send the patient completely out of my system. The question is, do I need to co-manage this with a GYN oncologist? I must say that the only one I've had in private practice, I have sent out to a oncologist, just because I didn't feel comfortable managing it by myself. So I just wanted to find out, like, in reality, do I have to do that?
No, in reality, you do not. And as a generalist, it's within our scope of privileges to follow up a molar pregnancy and to rule out the possibility of GTN. And that's what we're doing with our serial titers and our follow-up and our careful contraception and things like that. Once we get to a point where we have a titer that plateaus or goes back up, or we're worried about GTN, she needs then to go to GYN oncology. So suspected or confirmed GTN is an oncology issue then. So we would refer out. We would probably, do the basic workup. We get an ultrasound, we get a chest X-ray, we get a CT of her liver and her brain. We'd prepare and get the materials, and then we would send her off to the oncologist for further evaluation. But managing a molar pregnancy and its follow-up is complete within our purview. And in the exam, if you were taking an oral exam, you would describe that this is what you could do, but in your experience, you would be more comfortable referring out to GYN oncology, and they would be fine with that. That's conservative management. But we should recommend that we are it's within our purview to do the follow-up. If there's any suggestion of GTN, we should ship her.
Thank you so much.
Good deal. Thank you for doing that. That was actually really nicely well done. Let me get to Evan for just a second, and then I think Samantha has a question. We'll come back to Dr. Schweik for just a second. Evan, can you hear us okay?
Yes.
Great. Thanks for joining us, and welcome to our webinars. This will be a GYN question coming up here next. During a TVH, you believe you incurred an incidental cystotomy. So cystotomy during a vaginal hysterectomy. Part A, what would you do first?
So I would initially do a cystoscopy to identify where the defect was located. If it was near the trigone or where the ureter is involved, the ureter, anything else was involved.
Good. Let's stop there for just a moment. When we're doing a vaginal hysterectomy and we're doing our anterior colpotomy, that's where I think we would get the cystotomy. What portion of the bladder would you expect that we're in?
I would expect to be near the trigone, or
it is the trigone. We are right on the trigone. Yeah, because when we're looking at the sort of the cervical vesical peritoneal fold there and the reflection of the bladder, at the level of the internal os is sort of where we expect our ureteral orifices to be off to either side. We're right at that level, so you're right. So it's absolutely the trigone, and cystoscopy to evaluate that is the first thing that you would do. Excellent. Excellent answer. Part B, how would you evaluate the situation? So then looking at your cystoscopy, I think what they're asking is, what information do you want to get from your cystoscopy? We should have a short list of stuff that we want to kind of check out and check off.
The size would be of concern. Were the ureters involved at all?
Good.
Those are the main things I'm thinking of.
Yes, I think the length or size of it, the orientation, sort of, we're thinking about where the ureteral orifices are, and is there any possibility that the ureteral orifices have been injured or compromised, as looking at where this laceration went. And finally, also, we do want to have a good mental image of this, so we want to be sure that we are constructing our repair of this thing in such a way that we have in our mind where the ureteral orifices are, so that if there's no injury to the ureters, we don't incur one by putting a stitch too close to the ureter. So those are you're right, those are the basic things to check out: where it is in the bladder, its size, its orientation, especially relative to the orifices, and how we would construct our repair in such a way that we minimize our repair injuring the orifices. So how would you manage a cystotomy here? I think this is just a nuts and bolts question about how actually do you do the repair after you've evaluated all those things.
I would call the urologist, but the urologist is gone, I'm sure. But so if I were to have to do it, or what the urologist is doing is a 2-layer closure, getting the mucosal layer initially, and then the surface layer of the bladder. And, ensuring that the urethral orifices are not compromised or stitched within the repair.
Okay. How many layers are you doing for your repair?
I guess the trigone I would do 3.
Okay. What would you incorporate into each one of those layers? What tissues would you incorporate?
The mucosa. Good. On the initial layer, and then the muscularis.
Okay.
And then the peritoneal layer.
Sounds good. Yeah. So I think mucosa and submucosa, and then sort of as a sandwich layer in between, we want to get the muscularis really well put together, and then maybe outer muscularis and kind of the vaginal mucosa, or vaginal mucosa and submucosa. I think that would be a nice 3-layer sandwich there. That actually sounds perfect. Good. Part B, discuss the use of cystoscopy in your hysterectomy cases. So what they're asking is, when you're doing hysterectomies in general, how do you decide when to do a cystoscopy?
Right. I have a few on my case list, but I don't do them routinely on everyone.
That's fine.
I only do it if there were difficult cases where there was difficult dissection of the bladder, like if the patient had previous C-sections and there was a lot of adhesions between the bladder and the hysterectomy, large fibroids that could have compromised where the ureters were. They could have been compromised with the uterine vessel closure. Any really difficult case, I plan on doing a cystoscopy just to make sure everything's repaired correctly.
That sounds perfect. Again, that's careful conservative management. That would be fine. Many of our candidates might actually be universal cystoscopists. I kind of tend toward that myself. It is perfectly fine to be that way. They will have no problem. If you're a selective cystoscopist, which Evan, I think is what you are, what they want to hear is that you really are assessing the difficulty level of the case, the acuity of the case, and the likelihood that you may have inadvertently injured the ureter. We don't really want to talk about this in terms of the types of hysterectomy. So we wouldn't say, well, I do it for all my vaginal hysterectomies, but not for my laparoscopic. Right. That would get you into trouble. I think you want to talk about it case by case based on acuity. And that actually, I think you give a really nice answer to that. That was very nicely done. Great. So written exam questions in here can go through all sorts of stuff about the ureter. They would ask actually maybe about when a cystotomy occurs during a hysterectomy, the portion of the bladder most likely to have been entered is, and they would give you the dome of the bladder, the mid portion of the bladder, the trigone of the bladder. They would ask you, a cystoscopy in evaluating cystostomy is important for each of the following features, and they want you to tick off the things that you want to check out when you're doing cystoscopy, and they might put a sort of a distractor in there or something that's not correct, just to throw you off. But it would be using that same information and just sort of looking at what sort of is part of the question, and does anything sort of seem to be an outlier that you wouldn't select as an answer. But Evan, you did a nice job. That was a really strong performance on a question that most of us get into. At some point in the exam, they ask us about bladder injuries with hysterectomies, and TVH is their favorite, I think. Good, nicely done. Thank you. Let's move on for a minute. I think let's get back to Samantha, who I think it might have a question. Samantha, just trying to get you unmuted. There you go. Yes, Samantha, go ahead.
For molar pregnancy, did you say that you trend the beta HCG in intervals of 3 months after it's been negative for 3 months?
You do weekly until you have 3 weekly negative levels. So it's going to go down, 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 and it hits negative. And once it hits negative, then you need to get a total of 3 weekly negatives. So every week until you got 3. Then once a month for 3 monthly negatives.
Okay.
And then it used to be every 3 months after that for a year. It's now every 3 months to at least 6 months and a year, depending on who you are. So it's weekly. Oh. So negative, you want to be weekly times 3, monthly times 3, and then every 3 months, out to somewhere between 6 months and a year, depending on what your oncologist tells you he or she wants to do.
I think per up to date, and also I discussed this with Dr. Millian as well, and my oncologist. It's actually now only once a month for 3 months, and then no further evaluation if it's a complete molar pregnancy, or just 1 month if it's incomplete, and you don't have to do any further surveillance.
Okay, but right, the important thing is with a complete mole, we're more concerned and we would go on a little bit longer. And that actually, it will depend on where you are. For instance, around in this area, our oncologists all insist on 6 months no matter what.
Okay.
So that's fine. You just want to discuss sort of the general approach, but the idea is weekly, monthly. I would sort of say in general, we're thinking out to about 6 months or so tends to still be a reasonable consensus if they're asking about that in the exam. Okay. They wouldn't in the exam put a question in which it was specific as HCG titers should be performed out to 3 months, 4 months, 6 months, 8 months. They wouldn't make you pick among those because there is certainly some variation. So that is not a multiple choice question you would be asked.
Okay, and then the other question that I have is for this question for the TVH, you would actually finish your TVH and then do the cystoscopy and the cystotomy repair. Is that correct?
I would not do that, and I would not recommend that we should talk about that if we were in an oral exam situation. The issue with the cystotomy is we have now an unexpected and unintended injury to the bladder, which means we're having difficulty dissecting our planes. What the examiners would want to hear is that we now recognize that we sort of need to be a little bit more cautious. So we want to evaluate this very carefully. It would be reasonable to repair it and then probably to move on. If you were to continue with the hysterectomy, you'd want to be sure you evaluated it very carefully. And when you came back, you'd want to be sure that you went back and reevaluated for any further injury that might have turned up. People who are sort of conservative vaginal surgeons would say usually you want to repair it and be sure that you have your planes and sort of get the tissue layers constructed so that if you're dissecting in the case where you've got sort of a cystotomy hanging in front of you, there is a greater risk that you're going to incur more injury as you go up, and you may be close to the ureters. So conservative management would say repair it and then be sure you have your planes and then continue on. And then at the end of the case, come back and do one last cystoscopy, check your ureters really carefully. There are many people out there, I'm sure, who do go ahead and complete the hysterectomy and then come back and repair it. And they much more experienced surgeons. In general, if you were taking an oral exam, the preferred answer would be fix it first to get all your tissue layers and planes back to normal, and then carry on. And you would then be decreasing your risk of further inadvertent injury.
Okay, that's helpful. Thank you.
Thank you. Thanks for doing that. We have a few more minutes here. If any one of you would like to click the raise your hand button, let's see if we can get one more case in. Then we'll stop for questions for just a few minutes. And thank you, Diana. Thank you very much. Let me get you unmuted here for a second. Let's see, Diana, if you can unmute yourself for a second. There we go. See, I think I might have you here.
Hello.
Oh, I had you there. Sorry, Diana, are you there?
Yes.
Yeah, we got you. Thanks.
Okay.
Let's do one last case together. This is going to be an office practice case.
Okay.
48-year-old woman presents reporting 8 months of increasing daily urine leakage with activity. This is a Urogyn question. Describe your office evaluation of such a case. So 8 months of increasing urine leakage with activity, it sounds like.
Right. So in this patient, I would obviously start with her history. And so it's been 8 months. So, you know, we would assess the severity. So how many pads is she using? Is she limiting her activities because of this incontinence? I would also evaluate if there's associated urinary urgency or frequency related to this leakage. I would also assess, you know, what kind of fluids is she drinking that might be provoking this leakage of urine, and also any signs or any symptoms of maybe an infection that could also be causing some of these symptoms. So that would be my history. Yep.
Sounds good. So then move on to maybe do just a minute on physical exam. What would you want to be looking for on an exam?
So on exam, so urinary leakage with activity, I would be thinking about stress urinary incontinence. And so I would think about, on exam, I can have her cough or bear down to assess, to do a cough stress test, or to assess for maybe urethral hypermobility. I mean, you can also, I don't know that it's still done. You can also do a Q-tip test to assess the angle or the change in the angle of the urethrovesical junction.
Sure, that can be done also. Good.
Yep.
Good. Sounds good. And then any testing that you would do, lab testing or otherwise?
Sure. So I would also test at least like a urine dipstick to assess if there's any abnormalities, and obviously if there's anything abnormal on her dipstick, then I would send for a urinalysis or a urine culture. You can also do, I mean, you don't have to, but you can also assess for, well, actually I don't know that you have to, but a post-void residual.
You can. That's a reasonable thing to do. Yes.
Yeah.
That's true. Just curious, how would a post-void residual help you here? What might that tell you as far as what's going on here?
So I guess for the post-void residual, you can determine if she's truly emptying her bladder. So I mean, that's really what it would be to assess.
And if she wouldn't, is there a particular type of incontinence that don't think you've mentioned yet that we might be thinking
of? Overflow incontinence?
Exactly. Yes. Yes. So I think in here we're thinking about genuine anatomic stress incontinence. We're thinking about neuromuscular incontinence or overactive bladder issues due to instability. We also would be thinking about overflow incontinence, and that came up just because as you were talking, I suddenly thought of what would be a great Witten board examination question for something like this. It would be a 48-year-old woman presents with 8 months of daily urine leakage, not specifying anything else. Possible causes include each of the following, except A would be anatomic stress incontinence, B would be neuromuscular incontinence, C would be overflow incontinence, and D would be all of the above are correct. And they'd be looking maybe for whether people would kick out overflow incontinence and pick that as the one that doesn't belong, but in fact, all of them are on the differential diagnosis. So again, a way in which they can use this knowledge to sort of make us think a little bit more carefully about the question. But you're absolutely right, and that would be in my differential diagnosis. Another board examination question would be the least common cause of those symptoms would be, and overflow. It would be probably, first would be overactive bladder, second would be genuine anatomic stress, and the less likely would be overflow incontinence. So part B, moving on to oral board exam here, what initial management steps would you recommend? So now you've worked her up, and notice it doesn't tell us what kind of incontinence she has, so you get to pick, depending on what you think it is.
Okay, well, if she's saying, so like I said before, the first thing that comes to mind, because she's leaking with activity, is stress urinary incontinence. And so for these patients, I usually recommend, in addition to counseling them that it's not a dangerous condition, that they don't necessarily have to do anything about it, because, and if they do, it really depends on how much it bothers them. And then they can always do pelvic floor exercises or Kegel exercises to strengthen the muscles. They can also do a pessary, for device to help support the urethra, and then surgery. You can also do surgery, but for that, you can refer for a urogyne to do.
Good. That sounds great. I think we would, depending on what it is, it sounds like we're deciding it's anatomic stress incontinence, and that would be pelvic floor physical therapy, pessary use, surgery. I think maybe in that order. Good. When would you recommend placement of a suburethral sling? So now they're talking about what are your indications for recommending surgery in particular?
So I would recommend it in patients who, well, again, I think with incontinence, it really depends on the severity. So if, they can certainly choose to skip all the other steps and go for surgery, but I would probably be leaning more towards to a person who has tried, the conservative measures and has not gotten any improvement in their symptoms, and I would, of course, send her to surgery if she chooses. Yes.
Good. So sort of short answer. What sort of people would be a candidate then for actually a suburethral sling? Just the very specifics. It sounds like it's people who would be a candidate for surgery rather than the other more conservative stuff that you wanted to try.
I mean, I guess a young, healthy patient with a straight, I'm sorry, with a more clear diagnosis of stress urinary incontinence.
Okay.
Whether on physical exam. Okay. I think that's what you're getting at.
Okay. Well, thinking about, when would we actually talk about surgery? Because surgery comes last. So I think one thing we would say is people who have failed the other things. So physical therapy for the bladder didn't work. They couldn't tolerate a pessary or didn't want to do a pessary and maybe elected a sling. They have extreme, just uncontrollable stress incontinence, where other modalities aren't going to work, and you really need to surgically support the proximal urethra. Those would be, some things. So we think we're thinking for people who really have a more advanced problem, or just like, when do you do a hysterectomy? When they failed conservative therapy. It's really here it's when they failed conservative therapy. So part D, last part, and then we're done for the evening. Discuss the complications of suburethral slings, which is a really common topic. So what sort of things could turn up as far as post-operative complications with having like a TVT or a TOT?
Sure. So some post-operative complication can include urinary tract infection, I guess, injury to the organs. You can also experience a avoiding dysfunction.
Very good.
Yes. Let's see what else. Avoiding dysfunction, or, in the long term can experience, mesh exposure.
Yes.
Due to the mesh.
Yeah, I think the top three would be, first of all, a UTI, urinary tract infection. The second would be either sort of unmasking if it's a mixed incontinence, a neuromuscular or sort of overactive bladder syndrome, or the operation itself can actually trigger that in many people for a temporary period of time, and you manage it medically. Next would be overtensioning of the sling, which you manage by just sort of separating the sling and just letting it reheal. And then you get into things like surgical site infections, hematomas, mesh erosions, you know, the more serious things, but fortunately the much less common things. Perfect, Diana, that was very well done. I think you have a command of this topic. That was really nicely put together. Is there anything you'd like to chat about, or just any questions you have about this before we finish up?
I think I'm good, thank you.
Great, thank you very much. Let me get up to Courtney just for a second. Courtney, did you have a question, or did you want to talk about anything in particular?
No, sorry, I didn't realize my hand was still up.
Oh no, that's okay. No, I appreciate it. We do need to finish for this evening, just for a minute, because they're probably about 7 minutes before the GoToWebinar cuts us off. If any of you have any questions about sort of where things are going with the new ABOG plan, if you just want to click the raise your hand button, I'll try to entertain a few of those. I think the important thing is that with the October 13th webinar, we should all, they'll send out the time for that. We should all be tuning into that, and we will learn a little bit more about what their plans are for that. And along in there, I think we may hear some things that when we could start to talk about as far as sort of what the questions are going to be like and how the exam is going to be structured. But I think the firm advice for the time being is this will be a written board examination, which is going to stress the sort of things that we talk about in an oral board exam, which is our process of evaluating patients, developing a differential diagnosis, figuring out how to proceed from beginning to end of a workup, putting things in priority, understanding the potential risks and benefits of procedures, the complications, when to recommend surgery, when not to recommend surgery. And it will be in a multiple choice format, which is something that we've all, whether we realize it or not, did a lot of in the written board examination, but I think it's going to be much more slanted that way. Jessica has her hand raised. Jessica, I'm trying to unmute you. If you'd like to ask a question, if you can just unmute yourself for a second, I can get to you. Hi,
yeah,
Jessica, go ahead. Hey.
Yeah, I had a question related to that.
Yeah.
As I was thinking back about the written board exam a couple years ago, and one of the areas that I was also sort of wondering about as part of studying was the maintenance of certification exams that are done by some people. Can you speak a little bit to how the format of that particular exam is and how it might compare to our prior written board exam we may have taken a couple of years ago?
Yes, actually, I have taken 2 maintenance of certification exams. We do it every 6 years. It's optional now. I still do it just because I'm really interested in taking it and seeing how they word their questions. It's sort of like intelligence gathering. But yes, it is a 100-question exam. The question formats are very similar to the written board examination. The questions are not quite as different. The difficulty factor is a little bit low because I think they want most people to pass. But although the questions are a bit easier, the formats are very much the same. They're asking us about sort of our knowledge of how to implement new concepts into practice and sort of what have been recent changes in the standard of care, what would we consider as far as reasonable options for managing a patient, and they'll put in some things which are no longer recommended and some things that are, and we have to figure out which is which. So it is very much that slant as well. And I think this examination will be very much along those lines. The difficulty factor is, the difficult thing about this is Dr. Chermoth has said, the oral board exam is easier than the written board exam because you can have a nice conversation and talk about the general management of preterm labor. And as long as you're within the bounds of the standard of care, you're okay. With a written board examination, you have to go with very specific bits of information, and they only give you certain things to choose from. And that's what we in testing call information control. They can sort of give you some information and provide something in question. They will not tell you some information in the question that makes it ambiguous. The answer choices will probably not be the first answer choice that you want for the most obvious thing. You'll have to choose from more difficult alternatives. And these are all ways in which they make us think, and they make us sort of, they ferret out how we actually think our way through, and we sort of figure out where to start and prioritize what's the best thing to do first and what's the not best thing to do first and second. And there's a lot of that goes on in how they structure these questions. Prologues are very useful. They are written by the same people who write our written board examinations, and they're very lengthy and wordy and hard to read through. But they are the format. They actually test us on our thinking as well as our knowledge. And they're a nice place to go to sort of practice how to get into this mode of how to think our way through these questions. And again, the Exam Pro faculty, I believe, will be talking about this. I think we'll probably be sort of starting to move to that in our presentations as we go forward with our webinars and such as well. But we will let you know about that shortly. Jessica, does that help?
Yeah, thank you.
Great, thank you. Thank you all for attending. We are going to close down for the evening. We'll be continuing on starting on Sunday. We will see whether we think we are going to do some case list review as well, because that's useful practice for the exam. But in the next few days, we should have a email out from the central office about how we're going to structure the webinars going forward. And next week, that October 13th ABOG webinar is definitely something for all of us to check into as well. For now, thank you all for attending with us. Have a very pleasant rest of the evening.